So thanks everybody. I'm sad, of course, that we're not in person, but excited to be here today to take you through what we know right now about maintenance therapy. We'll focus on primary maintenance therapy, but also get into second line for those of you that may not have gotten any maintenance in your front line. And these are my disclosures. And this is just a little review of our objectives. We'll have a couple of case studies, talk about contemporary frontline maintenance options and how do we figure that out? How do we decide? Talk about second line and beyond, and then also any adverse events and toxicity concerns we might experience. So first, let's start with a case. This was a 41-year-old woman in my clinic who presented with bloating and abdominal pain and was noted only to have hypertension, high blood pressure that did require multiple medications. And this was her imaging. So, this is a CT scan. The back, oops, I'm touching this. The spine is here, the front is here, and this area in the pelvis is not supposed to be here. You can see this little circle up here is the uterus, and below it is her cancer, which is involving both ovaries. It was also kind of coming along here along the bowel, which is something called carcinomatosis or a mental disease. And so that's what her imaging showed, was bilateral ovarian masses and peritoneal carcinomatosis. So she underwent surgery, an optimal tumor reductive surgery, meaning we removed all evidence of disease to what's called no gross residual, which is no visible residual. And that's the goal, that's what we want. And her pathology was a high-grade serous, so the most common ovarian cancer, and it was involving everything we removed, including the ovaries, uterus, omentum, and diaphragm.
Dr. Westin, I hate to interrupt you, but can you maximize your screen? Because we see.
Oh yeah, that's what I was asking, if you guys were seeing what display you were seeing.
There you go. There you go. Perfect.
Okay, perfect. So, we did do testing, right? So this is the bottom line. We need to do both germline and somatic testing. So germline is testing in the IV to look for hereditary cancer gene abnormalities, and specifically BRCA. And if that's not found, then we'll look at somatic, and somatic is testing within the tumor. Both of these are exactly the same as far as importance. Now, germline is important not only for treatment and maintenance strategies, but also for the rest of the family to be aware of their risk of ovarian or breast or other cancers. Somatic is only important in regards to treatment. Somatic BRCA mutation does not indicate that that patient's family may have risk of future cancers. So she got chemo, IV, 6 cycles of carboplatin and paclitaxel, our standard of care, and was NED at the completion of her treatment. Her only post-treatment toxicity was just some mild neuropathy from the paclitaxel. And so the question is what to do here. Back in the day, we did nothing. We would just watch and wait, active surveillance. But for this patient, with a BRCA mutation, we have an absolute standard of care, PARP inhibition. And in the case of this patient, she was started on olaparib, 300 milligrams twice daily. Now let's look a little bit about the history and also some of the data that supported this choice. So first, I'd be remiss if I didn't talk about some of the historical maintenance trials. Now this was GOG 178. We didn't have a lot of targeted therapies back then. And so this was looking at, can we or should we continue more chemotherapy? So it looked at 3 cycles versus 12 cycles. That's 1 year of paclitaxel. So you can imagine quite a bit of chemotherapy, quite a bit of toxicity. It demonstrated an improvement in progression-free survival and was actually stopped early because everyone got so excited that that should be the new standard of care. But unfortunately, and this is really important when we're looking at maintenance, it did not show overall survival benefit. And because of the toxicity, it didn't really move forward. And the thing that was missing from this trial was a placebo. So yes, 12 might improve over 3, but what does the no treatment or active surveillance add? And so that question was answered by the GOG 212 study, which looked at, again, in upfront ovarian cancer, complete response to therapy, randomized to either Taxol or paclitaxel or a Taxol derivative called Zyotax versus no therapy. And unfortunately, there was no difference in survival rate. And this really kind of put chemotherapy as a maintenance to the side. Now, the AGO-OVAR16 study looked at pazopanib, which is a pill. It's kind of a dirty kinase inhibitor. We call it that because it had multiple targets, including VEGFR, PDGFR, c-KIT, and FGFR. And what they did was use this as a pure maintenance strategy after complete response to therapy, or at least some response to therapy. And they were randomized to the pazopanib for 24 months versus no therapy. Now, they did see a benefit in progression-free survival, but no subsequent benefit in overall survival. And this did not move forward. Now, this can kind of feel kind of depressing. You're like, Westin, God, I heard you were perky and optimistic. Why are you showing me all these negatives? Well, now we're going to transition to some of the more positive studies and really some of the things that changed our standard of care over the last 5 to 6 years. So first was the addition of bevacizumab. Now, bevacizumab is an anti-angiogenic, meaning it attacks the bad blood vessels that supply the tumor, as well as attacking the tumor directly. And it's been able to be given successfully with chemotherapy and was looked at in 2 studies, 218 and ICON-7, where bevacizumab was given with chemo, followed by bevacizumab maintenance. And the bottom line is that it improved the progression-free survival and potentially overall survival in a select subset of aggressive-looking ovarian cancer. So patients with stage 4 disease or patients with suboptimal tumor reductions, that kind of thing. So this became a standard of care. Although I would say that use was mixed. Some people give it to every patient, some people give it to select patients, and really it was the baseline, or kind of the floor on which we judged future targeted therapies. Now, one of the questions we had, you can see these curves have what we call banana curves. See how they look like a banana? That banana is when you stop bevacizumab, you often lose a lot of your benefit. So the question came, should we continue bevacizumab longer? And this was the BOOST study, where they continued bevacizumab beyond the usual 15 cycles into 30 cycles. And unfortunately, I mean, I think I've taught you guys this before, but I'll remind you, with a curve like this, you want space in between. The more space, the more benefit for your intervention in letting people live longer without their cancer coming back and their overall survival. This did not meet that. So longer bevacizumab was not better. So then comes the question, what else could be better? Now, PARP inhibitors have been very exciting in ovarian cancer. You've heard a little bit about that already from Dr. Alvarez, but I'll do a quick primer around why we use that. So PARP inhibitors are involved in DNA damage repair. So when we have a single-stranded DNA break, occurs all the time from sun, UV rays, radiation, that kind of thing. PARP comes in and fixes it. So if we block PARP, the cell then replicates and we get double-stranded DNA breaks. Now, double-stranded DNA breaks are repaired by something called homologous recombination. And in a normal cell, it will have no problem with the accumulation of double-stranded DNA breaks, and it will just fix its problem and live on. However, if you have a cancer cell that has deficiency in this repair, it can't do what it needs to do, then that cell will end up having cellular catastrophe and cellular death. So this is why PARP inhibitors hurt cells that have BRCA mutations or other abnormalities in this repair pathway. Now, BRCA mutations are the clear and easiest way for us to identify the patient population that may benefit from a PARP inhibitor. However, we do also have different scores that are available. These are commercially available. Your doctor can order for you. And they're usually made up of 1 or 2 things. The bottom line is all of them have looking for something called loss of heterozygosity. And some others might have things like large-scale state transitions or telomeric allelic imbalance. These are all just abnormalities in the chromosomes that can lead to genomic instability and subsequent sensitivity to PARP inhibitors. So we're just trying to get a sense of who will benefit the most. Now that we've level set around the importance of BRCA mutation, the potential importance of this homologous recombination deficiency score, let's look at some of the fun clinical data, because I promised you I have good news. So the first trial that looked at PARP inhibition in the upfront setting was the SOLO-1 trial. Now, this was a very select population, only patients with a BRCA mutation. That could be either germline, so hereditary, or somatic in the tumor. They were randomized 2-to-1 to either get the olaparib or a placebo after the completion of their upfront therapy. And the primary endpoint was how long could they live without their cancer coming back? That's progression-free survival. Now, again, Kaplan-Meier curve, this is a survival curve. We want to see a nice wide space between our intervention, olaparib, and placebo. This is a nice wide space. We could drive a truck through the space. We're very happy with this space. This was definitive to demonstrate that the use of olaparib improved progression-free survival. Now, we don't have overall survival yet, but what we've seen is getting out past 5 years, we have benefit. Now, I think one of the questions in the chat was, how long do I continue this? Should I stop? Should I not stop? Now, for this study, the drug was included for 2 years or utilized for 2 years. I want to highlight where on the curve 2 years is. See that curve continues to benefit after 2 years. So we feel pretty good about stopping the olaparib and letting you go live your life, and you're still going to continue to get that benefit. And in fact, there are rare side effects and adverse reactions to olaparib where people can develop leukemias and myelodysplastic syndromes. So we don't necessarily want to keep you on it forever in this upfront setting because we don't want to develop another problem in regards to that. And in fact, when these early studies have looked at leukemia and myelodysplastic syndromes, they have not really had an increased incidence. And I think that's because we're stopping it at a given time. Now, we mentioned how great bevacizumab is. And so can we add PARP to bevacizumab? This was PAOLA 1. And in this study, they randomized patients that had already gotten chemo with bevacizumab and then either added olaparib or didn't. And the overall group did very well. However, when they teased out the populations, this is why I taught you about HRD, the populations that got the most benefit are the ones that had a biomarker, whether that was either BRCA mutation or this middle group, which was HRD without a mutation. So you can see that's where the biggest benefit, the reduction in the chance of progression really occurred versus those patients with no biomarker didn't get much benefit. And that's why this is only FDA indicated in patients with an HRD tumor. And then finally, PRIMA, which is looking at PARP in all comers. Now, this population was a little more aggressive. It was a high-risk population, stage 4, or patients with residual disease after their resection, got randomized 2-to-1 to either niraparib, the PARP inhibitor, versus placebo, and again, found a benefit in all comers. Now, interestingly, this was also teased out, and again, the biggest benefit is in that population that has a biomarker, whether that's a mutation or HRD. However, there was enough of a clinically significant reduction in the risk of progression in that group without HRD, which is also called HRP, homologous recombination proficient. So this did get an all-comers indication. So PARP is here in the front line. So when we're talking about how we treat this patient population, we now have all these options, which is so great. We've got our chemo with or without bevacizumab. You can do IP chemo. All of those things are an option. And then comes our decision-making around, do we do a PARP inhibitor? Do we do PARP with bev? Do we do bevacizumab alone? And still there's an opportunity for active surveillance in that biomarker negative group, but it really comes down to shared medical decision-making with your doctor. So how do we decide whether or not we're incorporating maintenance therapy? Well, the indication, so that's what I mean by that is it FDA approved, right? So now we've got 2 PARP inhibitors that are FDA approved, both alone as well as olaparib in combination with bevacizumab. So we sit in that setting for strategy. We also are going to look at what is your BRCA status, what is the HRD status. All of that's going to factor in. But more importantly, where are you? How are you feeling? What are the side effects of these agents? What are you concerned about? What are the schedules of these agents? Some are given twice a day, some are given once a day. Does that matter to you? How many pills are you taking a day already? Is it going to be overwhelming to add a bunch more? So these are some of the things you'll talk through with your doctor. And then, of course, what are your existing adverse events? Do you have neuropathy? Do you have high blood pressure? Do you have nausea? Like, what's going on with you that could impact our decision-making for maintenance therapy? And then I would be remiss if I didn't mention cost. These drugs cost a lot. Now, we've come a long way with insurance coverage, but copays need to be considered. Some insurance companies do not cover the entire cost and will ask you to pay a copay. Most of the companies do have a copay assistance program, but still, you could end up paying a good amount out of pocket, and we want to weigh that with what your actual benefit is going to be. So what's coming next? We talked a little bit about single agent. We talked a little bit about the combination with bevacizumab, but there's a lot of other combinations coming down the pike. We have the Athena trial, which is combining PARP with immunotherapy, pure maintenance strategy with nivolumab. We have the first trial, which combined chemo with bevacizumab, with niraparib, the PARP inhibitor, with dostarlimab and immunotherapy. So would we potentially be giving a 3-drug chemo combination followed by a 2 or 3-drug maintenance? If this is positive, potentially. A lot of drugs being utilized up front here. There are 2 different studies that just completed with olaparib, the PARP inhibitor in the front line, including olaparib plus bevacizumab plus durvalumab, an immune oncology agent, or olaparib plus pembrolizumab. So I'm not trying to overwhelm you and like you're taking notes like crazy. The point is that there are a lot of large trials that just got completed that could potentially change the way we treat our patients with frontline. So really exciting days. And then finally, I just wanted to spend the last few minutes talking about what do we do for a patient that's in the recurrent setting. So this is a second case. This patient had stage 3 C high-grade serous ovarian cancer, was totally negative germline BRCA, got 6 cycles of IV weekly paclitaxel and carboplatin and had a complete response. Didn't get maintenance therapy at that time because it wasn't available to her. And unfortunately, a year later, her CA-125 is elevated at 574. Now, her imaging is not super clear. She's got a lot of fluid here, ascites, but otherwise we didn't see a lot of nodularity, not a lot of disease, just really this fluid kind of throughout the abdomen and pelvis. So we actually drained it and it was positive for adenocarcinoma and she was really highly motivated. So she wanted to get treatment. So we gave her IV pegylated liposomal doxorubicin and carboplatin, and she did achieve no evidence of disease after 6 cycles. So what helps us inform? We've got 3 trials that have completed maintenance therapy with PARP inhibitors, as well as trials with bevacizumab. Now, here's just a little cross-trial comparison. So looking at all the different trials. And the point I want to make here is when we add bevacizumab to chemo in the recurrent setting, we do better. We live longer without our cancer coming back. And in at least one study, patients lived longer. So there's a role for potentially utilizing bevacizumab, even if you use it in the upfront in this setting. Now, when we look at the studies of PARP inhibitors, we see overall a clear pattern of reduction in the risk of progression, again, across all 3 studies. So let me quickly go through those data. So the SOLO 2 study, sounds like SOLO 1, was a study looking at olaparib in the recurrent setting in patients with BRCA mutation, clearly positive, benefited patients in keeping their cancer from coming back, and was approved back in 2017. Recently, they reported their overall survival data, which has demonstrated patients lived longer by 13 months when they were treated with olaparib maintenance over placebo. So really exciting data, potentially informative to the upfront data, and very clear that this is something we want to do for our patients in recurrence. Similar data were reported with NOVA. NOVA looked at 2 different populations, the BRCA mutant population as well as the BRCA wild type population, saw benefit to niraparib in both patient populations. You can see those beautiful curves, patients living longer without their cancer coming back. And this also was approved in 2017. Did see similar results where we kind of teased out that population where the biggest benefit is in those patients that are HRD. However, patients that are platinum sensitive, that are sensitive to platinum, do seem to benefit from PARP. So we did still see some benefit in that population that did not have a biomarker. From an overall survival standpoint, we didn't see a significant benefit, and this is likely because a lot of these patients subsequently got a PARP inhibitor after participation on the trial. And then finally, the Ariel 3 study looked at rucaparib in a similar patient population where they looked at an all-comer population, but teased out each group, BRCA mutant, homologous recombination deficient, and completely biomarker negative, and found that rucaparib improved in all 3 groups progression-free survival. So the cancer did not come back as soon for that population. So really exciting to have 3 different options in this population. So we've talked about what our options are. We've talked about how we might decide. I just wanted to spend the last minute just to kind of give an overview of toxicity, because obviously if you're staying on these things for years, 2 years, 3 years, maybe longer, we want to know what it's going to do to affect us in the day-to-day. So our bottom line from a standpoint of how we discuss with practitioners is you got to be monitored closely in the beginning. So you're not going to start taking these pills and go off to Paris, lucky you if you can. You want to stay around and get monitored closely. You're going to maybe even have a weekly visit with the nurses, talk about symptoms, your vital signs, what do your labs look like? And we really are going to use, in the beginning, I always talk to my patients about finding their sweet spot. So where's the level that you can tolerate? We might start you at this level, but we may reduce you or pause you in order to get this to be tolerable. Here's just some of the things we can see across all the PARP inhibitors. The side effects are generally the same. We see things like anemia, low blood count, thrombocytopenia, so low platelets, and neutropenia. So those are your infection fighters. But these can be, again, managed. GI toxicity, typically low grade, early, easy to manage with some simple stuff, but we can see things like nausea and vomiting, decreased appetite, and diarrhea. So these are the things that your provider is going to ask you about to make sure that you're not experiencing it and you can tolerate this regimen. I think the trickiest thing to handle for PARP inhibitors in general is fatigue. And that's because we don't have a drug to give you. We can't give you a shot to reduce that fatigue. So for me, that's the biggest reason for my patients that we will do a dose reduction or a dose hold, is to let you get kind of your bearings again. I encourage people to exercise. I encourage activity because that really seems to help. But a lot of times if you have significant fatigue, you just need a lower dose, and that's okay. And then finally, we do see some kind of rare side effects like niraparib can cause high blood pressure. Olaparib, rucaparib, we can see an elevation in creatinine, which is indicative of potentially renal issues. So we look through those things. We handle those things as we go. So the bottom line is a lot of you will come off chemotherapy and be like, oh, I'm going on a pill. It's going to be magical. Even though it's just a pill, we can see side effects, but they're manageable. We're going to watch you really closely to make sure you get through those first few cycles of therapy. And once you get through those first few cycles, you're generally going to cruise and get the benefit that you deserve as far as extending time without cancer and potentially extending your life from these agents. So with that, I would just thank you all so much for your kind attention. And I hope to see everybody in person in May at the gala.